Hi, everybody. Welcome. Thank you for joining us. It's a lovely spring day here in New York City, which is where I am calling in from. My name is Rebecca Silver. I'm the SVP of Marketing at LetsGetChecked, and I'll be the moderator of this event. We'll just give a couple minutes to filter in, and then I'll introduce our wonderful panelists. But at first, I'd love to ask everyone to share in the chat where they are from, where they're calling in from. It's always great to get to know each other a bit better. So just type it in there. Another New York, love it. Indiana, Maryland. Virgin Islands, that's fun. North Carolina. Cool. Well, thank you all for being here today. Love it. This is going to be an open conversation. So any questions that you have throughout the event, please put it in the chat. You have an option to send it to either the host and panelists, or if you click, you can also send it to everyone. Probably, most likely, other people have your same questions. So we do encourage you to send it to everybody so people can see what other questions are being asked. But if you want to keep it private, you can certainly send to hosts and panelists as well. But please put your questions in there throughout the chat, and we'll keep this conversation as open as possible. All right, I'm going to hand it over to our panelists to introduce themselves. So I'll start with Ashley Harrison.
Hey everyone, I'm Ashley. I'm the nurse practitioner with Let's Get Checked. Really excited to be here with you guys and Dr. Levine, learn a lot about infertility and his great specialty. Thanks for coming, guys.
Hi, my name is Dr. Brian Levine. I am a practicing reproductive endocrinology and infertility specialist. I am also the founding partner and practice director here at CCRM New York, coming to you live from Midtown Manhattan. And thank you everyone for participating today. This is such an important conversation during National Infertility Awareness Week. Hence, I'm donning orange to help support all of our patients and everyone on their path to parenthood. But thank you for being here, and thank you to our hosts and moderator.
Great. Thanks so much. Okay, I'm gonna share just a bit more about Let's Get Checked. And myself, I've actually been in the fertility industry for a little over 10 years now. This is a topic that is very near and dear to my heart, as I think it is to all of us and many of us in the chat. Let's Get Checked is a healthcare solutions company. We have over 100 at-home health tests, including fertility hormone tests, cholesterol tests, thyroid tests, PCOS tests, as well as pharmacy services and virtual care services. So our mission is to make care really accessible to you from home. And we partner with clinics and doctors like Dr. Brian Levine, just making healthcare as accessible as possible and making sure you get health insights so you can empower yourself to take control of your health. I'm gonna pass it over to Ashley. And Ashley, please add anything else about Let's Get Checked. And you can then dive into the topic of this evening.
Yeah, so I think you gave a great overview of Let's Get Checked. But yeah, I'm the nurse practitioner here. I help with looking at all your results and giving personalized information based on your results. And I work a lot closely with our awesome nursing team as well. If you'll go to the next slides for me. So these are just a couple true or false questions, just some things to kind of get the topic started. So first things first, you guys can type it in the chat if you want, your answers, just so we can track those. But first one is your hormones need to be in perfect harmony, true or false? So yes. I'm hearing good, seeing lots of falses. This is indeed false. This is not the case. They don't have to be in perfect harmony. Many people's are not, in fact. 2, we were born with all the eggs we're ever going to have, true or false? Dr. Levine over here giving it away for everybody. So yeah, the answer is true. 3, there are tests that can tell you more about your fertility levels, true or false? Yes, this is true. Great test that you can get some early insight into your fertility levels even before you start trying to get pregnant. So those are always great. And Let's Get Checked, we offer many different tests that you can take a look at those hormones. So last one, being infertile means you'll never be able to have children. True or false?
Mel will have your babies for.
So this is false. So thank you, everyone. So we'll go ahead and get started on the first section. Thank you. So first things first, I'll just get us rolled off with kind of the basics behind are your different hormones. I will try to be quick. I know this isn't the most interesting stuff, and you guys may or may not be aware of some of these. But if you've had any kind of fertility lab tests, these are likely some that you've seen. So first two, progesterone and estradiol. Progesterone is a hormone very important for pregnancy. In fact, sometimes it's referred to as the pregnancy hormone. It's going to help thicken the cervical mucus. It's going to help with the implantation of the egg. If you do get pregnant, it helps to decrease the contractions of the uterus. So it's going to help decrease risk of preterm labor. Estradiol is the primary estrogen form in women of childbearing age. So that's the one we generally check for women who are trying to get pregnant. It's produced primarily in the ovaries. And so your estradiol levels are responsible for helping a lot of things, but thicken the lining of the uterus. It's also going to help with the cervical mucus right before you ovulate, going to help to kind of make it a little more slippery so that the sperm has an easier time of getting to the egg in your uterus. FSH is very important for growing the follicles in the ovaries. LH is the hormone we see when it spikes around mid-cycle. That's what causes you to actually ovulate. And then AMH is a hormone that you may or may not have heard of. It's a indirect test. It's a test where it's actually cells in your ovaries that create AMH, and it can be an indicator of your ovarian reserve or egg count, but it's not going to give us an exact number of how many eggs you have. It's also not going to tell us anything about the health of the eggs that you have. So those are some common misconceptions with AMH. Next slide, please. So this is a great kind of chart of the menstrual cycle. When we say menstrual cycle, we mean the first day that you start bleeding until the day before your next menstrual period. And this chart is a great example of why, if you've ever had any of these kinds of lab tests, your doctor will likely ask you what day your cycle you're in. At Let's Get Checked, we tell our customers to take it on specific days. And the reason is because we need to know what range to look at for what's normal. So the hormones that are represented in this chart are LH, FSH, progesterone, and estrogen. So over here at the beginning follicular phase, you really have FSH helping to grow those follicles. As they're growing, they're going to start increasing estrogen levels. With that increase of estrogen, it causes that stiff spike of the LH. Which causes you to ovulate. So here about mid-cycle, day 14 of a 28-day cycle is kind of what textbooks say, but most women, a lot of women are not having 28-day cycles. So just kind of around that mid time is usually when you ovulate, but some are before, some are after. And then after you ovulate here, you'll see your FSH, LH go down. Where that follicle left, that's now in the uterus, that area is now called the corpus luteum, and it's helping to secrete different hormones, estrogen and progesterone. If you do the egg does get fertilized, that egg's going to implant into the uterus. If you don't get pregnant, that egg just disintegrates and the corpus luteum eventually disintegrates, decreasing that estrogen and progesterone. That steep spike down here around day 28. And that's when you'll start your menstrual cycle back over again and start bleeding. So next slide. So when are you most fertile? So when we say your fertility window, it's really the best times to get pregnant are going to be the day you ovulate, of course, but also 5 days prior. And the reason for 5 days prior is sperm can live in the uterus for about 5 days. So those are times when, technically you could get pregnant. The egg is viable in the uterus for about 12 to 24 24 hours before it disintegrates as well. And there's lots of good apps out there where you can keep track of this. There's apps on your phone. I have an Apple phone. There's a health app on there where I can track my cycle. Very, very important, because it's too much for us to keep up with what day we're starting, when we're probably ovulating, but it's so important. And a lot of these apps will actually tell you when your predicted fertile days will be. It'll give you about 5 or 6 days in the mid-cycle that it would be recommended to be having sex if you do want to get pregnant. So those are some great things and tools you can have if you're interested in wanting to get pregnant. Dr. Levine, I'll hand it over to you.
Great. So, I think one of the hardest things that I have to do as a fertility doctor is combat many myths. I also kind of need to combat a lot of labels. And what I find that people come in with is this preconceived notions that because they're at a certain age or because they have a certain issue going on, like they need to be labeled either as infertile or as elderly or geriatric or advanced paternal age. And as someone who's dedicated their life to women's health care, as someone who's the father to 2 daughters, I have to say that one of the things we need to do is probably this week during National Infertility Awareness Week is really make a conscious effort to dissociate these two things, right? We do talk about age quite often, but I think we should probably start talking about more than just age, but kind of like treating infertility as an illness, treating it as something that's a real medical condition that requires attention beyond just how old are you. With that said, what we do know is that as you get older, your egg count goes down. And as you get older, the chances of having trouble goes up. The trouble you could have getting pregnant could be in having a chromosomal abnormality or a birth defect or disability, which typically is due to chromosomes, which is typically related to your age because you're born with all the eggs you'll ever have. But truth be told, it takes 2 to tango. And so when someone comes into the office and say, look, I've been trying for 6 months or I've been trying for a year and I'm not getting pregnant and I'm over or under 35, just hit me with it. Just tell me I'm infertile, like give me the scarlet eye and we'll get through this together. I kind of tell them, look, you're more than just a number, which means you're more than just your AMH. You're more than just your age. And by the way, who cares if it's normal biology that you started with 1 million eggs and you're down to a couple thousand? Because at the end of the day, we're talking about using just one good egg to get you a healthy pregnancy. Next slide. If you want to take a look at your age as a continuum, sure. You start with a lot, you end with a little. Most people use birth control at some point in their life. If you're on the pill for 5 years or more, it will help reduce your risk of ovarian and fallopian tube cancers by 50%, 50. So many people say, oh my gosh, I've been on the pill for 5 years, 10 years, 15 years. Did I kill my fertility? The answer is no, you probably did really good cancer prevention. And on the flip side, no matter however long you took the pill, you still walked around with those eggs the entire time. So your age has something to do with it. But in general, we know that when you're young, you have a lot. When you're older, you have few. And there are people like me who spend their entire lives dedicated to helping people to fight just their age. Next one. Next one. So what is infertility, right? So we have these really crazy definitions and they're all age related and they all suck. In fact, there's even a definition of infertility defined as unexplained infertility, which I call the laziest diagnosis possible, right? That's when the doctor says, you are so interesting, I have no interest in telling you what I really think is going on. I'm just pulling the trigger and calling you unexplained. Well, unexplained is also really frustrating because it means that someone probably gave up on you or your partner or both of you in trying to figure out what's the root of the problem. What we do know is that somewhere around 11% of individuals who are trying to get pregnant, or the 1 in 8, will have trouble getting pregnant at some point in their journey. Next slide. There's a bunch of different reasons why people can have trouble getting pregnant. 40% of the time is due to the guy, and 40% of the time is due to the girl. And then 20% of the time, it's either combined or unknown. And it could be due to issues with releasing an egg, that's ovulation. It could be due to lumps or bumps or abnormalities. Those are the uterine abnormalities, implantation issues. It can be due to just plumbing, right? The guy has no sperm coming out or the woman has no eggs coming down the tubes. Or it could be due to probably one of the most common inflammatory conditions that we poorly discuss, both as OBGYNs and as health professionals, which is endometriosis. Next slide. When it comes to male infertility, we always tell people, look, it takes two to tango, and men should know that they make sperm from the moment they go through puberty until a couple hours after death. And I always joke that it's, of course, the testicles that keep working even after the guy is dead, right? But truth be told, you make sperm and it takes about 72 days to make sperm. So if your partner is smoking or drinking or has an unhealthy lifestyle, it will take 3 months from whenever they implement change to see any benefit whatsoever. But sometimes you can't even change the outcomes, right? Sometimes there's actually a biological plausibility behind why you're having trouble getting pregnant. And the most common one that we see is that a guy can have a vein on the side of their testicles called a varicocele. So same way that old women get varicose veins in their legs, a guy can get a varicose vein on their testicle or their scrotum. And that elevates the temperature of the scrotum. And by elevating the temperature, they're basically cooking their sperm, which leads to abnormalities. Of course, there are other causes as well of male infertility. Next slide. So does endometriosis mean I can't get pregnant? No, but it is the third most common reason that people do in vitro fertilization or IVF. And it probably is the number one reason that people have painful periods or pain with intercourse. And what happens is that as a society, we don't do a very good job of discussing endometriosis. What we don't really do is talk to our OBGYNs about prevention of endometriosis. And because so many people take hormonal birth controls, which kind of puts their body in a quiet phase while on the pill, many people don't realize that they even have endometriosis and that they treated it at some point in their life by being on the pill. Next slide. Same with PCOS, a condition that's associated by having two of three things: irregular cycles, having excess androgens, which could be like oily skin, testosterone in your blood, facial hair, and having a very high egg count. And all you have to do is have two of the three things. Some women come into the office saying, oh God, I just pray that I don't have PCOS. Please tell me I don't. And I say to them, why? Like, who cares? Like, it's just the name of a condition. It doesn't define you as being infertile. It may define you as having an increased risk of having trouble getting pregnant or staying pregnant, or an increased risk of, for example, having gestational diabetes or an issue in pregnancy. But it's common and it's treatable. And truthfully, of all the things that I do as a practitioner, it's probably the easiest condition to treat because you typically need just a $5 pill called letrozole to help regulate someone's cycle. Next slide. So if you think you're having trouble getting pregnant or staying pregnant, or you just want to learn more about your body, go get help, right? Like, there's a lot of people out there. There are people like me, there are people like Ashley, there are great apps that are out there, there are great resources that are out there. There are lots of different ways that you can help tilt the tables in your favor with just information. Next slide. Okay, so options. We're going to go through this part rather quickly because we are getting so many incredible questions. We actually have 35 questions already, which is amazing. And so I will kind of do just a high level of each one. IUI, or intrauterine insemination, is the good old turkey baster. This means putting sperm in the right place at the right time in someone's cycle. You can do it with medication, without medication, but the big picture is that this is a low risk, low cost, low yield intervention. If you're trying to figure out how to time a cycle, you can use it. If you're trying to bypass the cervical mucus or someone has cervical factor, you can use it. If you're a same-sex female couple or a single female and you buy donor sperm, your doctor will probably choose this as the approach to try to get you pregnant. But the success rates for an IUI approximate somewhere around 20% in the best cases. So just know it's not a perfect science and not a sure bet. Next. We just addressed that one. Next. IVF, in vitro fertilization. It is like the best technology that we have today for getting people to get pregnant and stay pregnant. However, it's not the be all end all. And by definition, in vitro fertilization means that we are fertilizing or putting together eggs and sperm in a dish. With that said, there's lots of different ways to do it. So, for example, I work with CCRM, and CCRM, or the Colorado Center for Reproductive Medicine, is a bunch of really, really geeky people who love laboratory science. And we use a lot of high-tech solutions to figure out of how we can tilt the tables in a lab. But not every IVF lab is the same. With that said, IVF in general involves taking shots for 10 to 12 days, having a bunch of monitoring appointments, and then having a surgical procedure where you go to sleep for a couple minutes to remove or aspirate the eggs, combine them in a lab with sperm, and then ultimately grow them to embryos that are either transferred fresh or frozen for future use. Next. So how common are IVF births? They claim, and they being the CDC, that it's 1% to 2% of all US births. I think it has to be higher. I still don't understand because it feels like every single person who you see on TV used IVF to get pregnant. It feels like everyone knows someone who's done IVF. But maybe that's just because we're finally talking about it as well. And we're finally talking about people's struggles. But according to 2017 data from the CDC, it is 1% to 2%. Next. Egg and embryo freezing, always great to discuss. Thankfully, now that egg freezing has gotten to be so good, right, we're actually in the 10th year of egg freezing being commercially available in the United States. Before 2012 was deemed experimental. But now that we've all gotten so good at freezing eggs, it's very rare that people need to go use donor sperm or sperm from another individual to help protect or preserve their fertility as a young female. With that said, freezing eggs is basically the first steps of IVF. It's shots for 10 to 12 days, monitoring appointments, and a surgical procedure to have them removed. It just means at the end of that process, what we tend to do is take those eggs, freeze them by removing the water, so then they're permanently frozen, and there's no risk of crystals forming or freezer burn. And then for future use, we put them back in the laboratory to use them. You should just know that if you freeze your eggs, you still have to do IVF to get pregnant, right? You can't just put those eggs back in you in the future. Next. So LGBTQ plus fertility options are incredible because we're doing a terrible job today in discussing even the definitions of infertility. I said to you before, I hate labels. I hate these numbers, these age numbers, for example, we're using. Well, what we're finding is that if the definition of infertility is trying for 6 months or trying for a year, what are you going to do if you're someone who's not exposed to sperm, for example, in a same-sex female couple, or if you're a single female, or if you're in a same-sex male couple, if you're not being exposed to eggs? How can you, by definition, be, meeting the criteria of trying for 6 months or a year? And that's the problem with commercial insurance. Many of the insurance providers have these really weird definitions there that, in truth be told, are discriminatory as you look at treating the patients or the couple. Next. Okay, I'm going to take a break and bring this one to Ashley.
Sounds good. So we kind of covered ovarian reserve a little bit with AMH levels. It's a blood test you can take. We do offer it at LetsGetChecked. It can be good for a couple things. It can tell you ovarian reserve. Dr. Levine, correct me if I'm wrong. I think it can help predict if someone's going to do well with IVF as well, like if their AMH is higher. So it can be used for several different things, but it's not going to tell you the number of eggs you have. It's not going to tell you if you're infertile or not. It's not going to tell you the quality. So it's a good test, but it's not the only test. I think Dr. Brian did great job making that abundantly clear. There's a lot of different factors that go into infertility, and AMH being low are not something that you wanted. It's not the end all be all by any stretch of the imagination, but it is a good place to start for sure. So if you do find yourself having a low AMH level, very important to follow up with your OBGYN, talk about different options and discuss your wants for pregnancy if you're currently trying or want to have a baby in 5 years. Opens up a good conversation to have.
So I'll just say this because I can't resist. I refer to AMH as the gas in the tank. If you went to go rent a car and you went to go pick up the keys and you said to them, so how far can I go? And they just tell you, well, you got a full tank of gas. that information might help you to say, look, I can probably get from the rental car to the hotel or the rental car to the back to the airport, but you don't know what kind of car it is. You don't know how quickly you're going to burn through that gas. You don't know the performance of the vehicle. You don't know if you're renting a VW Bug or if you're renting like a truck. Same with AMH. You're more than just a number. And in fact, many clinics out there, I feel like, are doing a disservice to patients, a disservice to young women by saying, oh my gosh, your AMH is so low that if you don't act upon it today, well, you're going to be infertile before you know it. No, like that's ridiculous. You can't draw a line with a single point. You need 2 points, right? You need to know what's the slope of that line. So if you get an AMH that's really reassuring, mazel tov, repeat it in the future. If you get one that's really disheartening, I'm sorry, but repeat it in the future. Because you may have been a 0.5 for about the last 5 years. And if you get a 2.5, you could have been a 4.5 in the last 6 months. So get to know who you are and what your trend is, and you're more than just a single test. I'll leave this one to you.
Okay, sounds good. So if you are thinking about getting pregnant, just some things to consider. So first things first, make sure you're talking with your OBGYN. There's preconception counseling that you can discuss, your wants to get pregnant. They'll tell you exactly kind of the best formula, so to speak, of when you should be having intercourse to increase your chances of getting pregnant. Part of that is going to be tracking that cycle is very important. Nutrition and lifestyle, just having a good, clean, healthier diet, having a healthy weight can also be very important, and decreasing the things that are environmentally going to not be good if you get pregnant. So if you smoke, trying to stop smoking, not doing illicit drugs, cutting back on the alcohol, and again, trying at the right time. So tracking that cycle can be extremely important. Next slide. Dr. Levine, if you want to talk about the importance of vitamins.
Yeah, so, it's interesting. In my 4 years of med school, 4 years of residency, 3 years of fellowship, and now 7 years of practicing medicine out after training, I can tell you I've still never taken a single class or course on vitamins and supplements or nutrition, which is like really disturbing, right? Like if you think about like what I do every day is I help people tweak and improve and modify their chances. And then we don't even talk about some of the most powerful medications that we take, which is the food we put in our mouth and the supplements that we put in our mouths. And for example, AMH and other blood tests can be totally thrown off by what you're taking. Someone just asked this in the questions before, and so I'll integrate it. Yes, certain supplements can throw off blood tests. So make sure you're truthful and forthright with your practitioners. But what's also interesting is that people know that when you're trying to get pregnant, you should take a prenatal vitamin. But no doctor ever really knows which one to tell a patient to take besides whatever the drug rep just left some samples for that they have in their office. So when I finally went out to practice, I created 2 habits. The first habit is, ever since med school, I read every morning, and I've continued that habit throughout practice. So I read in the mornings before coming to work. And the second is, I've tried to learn more about supplementation with vitamins and with diet, and just, like what people call the alternative care, which really is the extra part of what we do. And so what I've learned is that the opportunity as a practitioner to help patients gain control in something that feels like where they've lost control is by guiding them for an evidence-based approach, by showing them that, look, you can do this, and this is just going to get you to that next place possible of where you're hoping to go, which is to get pregnant or stay pregnant. And so as I went on my journey to start to try to find, like, what is the right way to support someone, I learned very quickly it's not just a single pill. It's not just a single vitamin. It's not just getting Centrum Silver and just adding in a little vitamin D or, going to get some iron pills or whatnot. It's actually looking at a comprehensive approach of how do we help support you along your journey. So I ultimately landed on Perelel, which I have to say is just incredible because they embrace what I've always believed, which is there is no single pill solution to help you get all the supplementation that you need. There's a bunch of people much smarter than me who help advise them as well, including myself. But people who are actually really smart, who actually really understand how to optimize your body to start running this marathon that we call pregnancy, right? We know there's 3 trimesters of pregnancy, but there's also that first part of trying to get pregnant and that crazy later part of just trying to like stay alive after you have a kid at home, which could be really stressful and really deplete you as well. Next slide. So for those people who are trying to get pregnant, I advise people to use the conception support pack just because it's easy, right? Like I don't have to tell people, go download this coupon and go buy a bunch of different things, go to this store and that store. And like, God forbid their Amazon delivery didn't even like, drop off whatever it is because of supply chain. No, like just open a sachet. Inside, you're going to find your 5 main pills that you need. And those 5 pills that you have are going to be more than enough and more than adequate that even if you don't have the best diet, to make sure you have the best supplementation possible. To me, it was really important for the omegas, because this is probably the number one thing that people ask us about. People say all the time, like, what's the effects of going through infertility on fetal brain development and neurodevelopment? But the other thing is that CoQ10, which is probably the only substance that we know that can actually help support egg quality. Great studies, Bob Casper out of Canada, really well done. It's like impossible to tell someone to take another pill. So if it's just in your packet from the beginning, it just makes sense. So I openly support the conception support pack. I have it sitting in my office. I have a bunch of them right now. I'll show you here. It sits here. And I show patients, I'm like, look, this is pretty easy. Just like keep this in your bathroom, put it next to your toothbrush, and just take 1 sachet a day and just keep going. Next slide. This one's Ashley.
Thank you, Dr. Levine. So I saw some people asking questions too about testing. One about AMH tests, where you can get that. So Let's Get Checked. We do offer at home AMH testing right from your house. So very convenient. You can ship that back to our labs to get at very accurate results quickly to your cell phone. We also offer different tests, like someone was asking me about the urine LH tests, which are awesome. Those are over the counter. But if that wasn't really working for you, or you're having a hard time with that, we do have a at-home progesterone blood test. So this one was to be taken. So on a 28-day cycle, it's day 21 of your cycle, because that's when progesterone typically peaks in the in your menstrual cycle. But with that said, we know that most women do not have that perfect 28-day cycle. So if that's you, no problem. There's actually a calculator on our website where you can go in, type in your average cycle length, and it'll tell you what your day 21 is. So you'll know when you should take that progesterone test. We also have just general female hormone tests, which include estradiol, LH, FSH, and prolactin. And then our ovarian reserve is going to be our AMH test. PCOS test, we talked about that a little bit. It can cause symptoms like irregular periods, hirsutism, where you're getting kind of more like hair on the face, acne around the chin. So that's a good test to take if you're having those kinds of symptoms. Just a quick preliminary check. Look at your testosterone, your LH, and FSH. So all those can be great insights into your hormonal health. And it's really important to get a look at those early on. As Dr. Levine was saying, they're one point in time. So if you're interested, or you may not get the result you want, it's important to follow up and talk about that with your healthcare provider, but also to make sure you're continuing to check to see if that's just a trend and if things are improving. So, but yeah, you can go directly to our website. I think, Rebecca, if you go to the next slide, there's a code for you guys. If you want to use it, you can get 20% off our women's health tests, which include all the ones above. And then again, you can also, your first month of Perelel, you can go check that out too. So 20% off for your vitamins too.
That was fantastic. Thank you so much. And thank you everyone for your wonderful questions. I'm going to put them in some batches. And if you have more questions, please keep them coming. Let's talk first about hormones and fertility. We had one early on. How can I boost my fertility? Ashley, you spoke to that. Is there anything else you want to add there, or Dr. Levine, about things you can do to boost your fertility if you are trying to get pregnant?
Yeah, so I'll say there's three things. First is, why do you think you need to boost it? The practice of reproductive endocrinology and infertility is only as old as I am, which is about 42 years. And before that, apparently people were getting pregnant without help. So I'd say is, talk to your OBGYN and get to know your body. If you think things are off and you're having issues in your cycle regularity or whatnot, maybe figure out what that is. In the same regard, it takes two to tango. And so maybe you want to talk to your partner. And maybe you actually want to step back for a minute and stop intervening in what you think is, trying to help the process. Because sometimes you can be adding a lot of undue stress upon yourself and putting yourself into a real panic mode when you just need to kind of let things fall into place. Humans are not perfect at reproducing. And so it takes time. And that's why we tend to give people generous windows. But if you don't know your body, you don't know what feels right, and you don't know what's regular, then just go see a doctor. Like, don't try to Google yourself until you're just mind numb. Go see someone and talk to someone.
Thank you. Thanks. That was great. Well said. Thank you. There's a lot of questions about AMH. I'm going to dive into some of those. How often should you be taking an AMH test, Dr. Levine?
So this question has been coming up since the famous paper in 2006 in the Gray Journal of OBGYN that discussed AMH and that you could do this on a birth control pill. And what it said in that initial study was that AMH is a test that's highly accurate, no matter if you're on oral contraceptives or not. However, what we have now learned 15 plus years later is that being on the pill does not give you an accurate result. And what we do know is that there are certain differences depending upon which assay you're using, which lab you're using. As such, if you had an AMH that was done, you should repeat it most likely 6 months later if you're in a surveillance phase where you need to kind of just follow yourself along, and do it at the same place you previously did it. Get it done in the same lab or the same machine or the same approach. And if you're changing your birth control pill or you're stopping your pill or changing your form of contraception or whatnot, just know that your AMH could need some time to rebound or come back. I'll also say, if you're taking excessive levels of biotin, which a lot of people have been doing recently for hair and nail growth, you should just know that actually can throw off the AMH assay and make it look like your AMH is really, really low when it's not. So when in doubt, check your AMH in the setting of also getting an ultrasound. Fertility doctors love multi-point analyses, right? Multiple ways to assess the same question with different approaches. Blood work and ultrasound is the best way to do that.
Thank you so much. And do you also see benefits in at-home testing and doing that as a first step?
100%, right? So New York State's one of these weird states where at-home testing has been kind of an issue getting through. But with that said, we just got through a crazy part of our lives with this pandemic. And if we learned anything at all from this pandemic, is that breaking down the barriers of access to care is what we need to do as care providers. So if one of the barriers is actually leaving your bubble or leaving your quarantine and coming into the clinic, then bring the clinic to yourself. At-home testing is an unbelievable opportunity for people to learn about who they are and what they need, if they need anything at all.
Thank you. And Ashley, I know this is what you do every day. So anything to add on at-home testing generally?
Yeah, no, completely agree. And two, it's so convenient being able to go on our website, look at our different tests. We have 4 different ones that we just named before. And so you have a choice and you can really take agency of your own health, which I think is awesome. Very powerful thing. Yeah.
Yep. A really great question came in around PCOS. And when you have PCOS, you typically have higher AMH. Is there another way for you to measure egg count if you have PCOS and are going to have a higher AMH as a result?
So the question I would ask the person is, so what? Why does it matter? I've seen patients before where they have an AMH that comes back at greater than 24 or greater than 15 or greater than 12. And the woman says to me, see, my fertility's been declining. It's gone from 24 to 15 to 12. And it's like, no, you actually need to read the test carefully. Once you had it done at LabCorp, once you had it done at Quest, and then once you had it done in a fertility clinic, and each place has a cutoff for what the higher end is of that test. What I would say is, in general, if you have PCOS, most likely your AMH will be elevated, but that's not going to predict your ability to either get pregnant or stay pregnant. Instead, having regular cycles and being ovulatory is what's going to help you get pregnant. So that's the more important part of the story.
Thank you. Let's talk about egg freezing for a bit. At what age do you recommend women start to think about egg freezing, and what will be the upper cutoff of being able to do egg freezing?
So one of the most frustrating parts of my job is demystifying or de-Googling someone who's gotten themselves into a rabbit hole. Like I said, when I started this whole conversation with you this evening, there's a lot of misbeliefs and misconceptions about what it means at a certain age. People label themselves at certain ages, and we really need to stop doing that, right? Like, we actually know that that's not beneficial, especially because we should just be guiding people along their journeys. We shouldn't be forcing people into things. With that said, it feels like right now there's a fertility clinic on every single corner next to a Starbucks. And if you go to certain clinics, they're going to tell you, well, by the time that you reach the clinic, you should have froze your eggs yesterday. And if you haven't froze your eggs by yesterday, we have a plan for you today. And I hate that, right? Like, it should be something that you partner with your doctor. It should be something that you partner with the conversation. Egg freezing should not be taken lightly, because if you don't approach it in a meaningful way and you get a bad outcome, which means few eggs when you expect a lot of eggs, all that does is mess with your head. And so no matter how pretty it is or how yellow it is, or whatever else, like, sometimes you need to just take a step back and say, hey, I'm not going to rush into an egg freezing approach till I know I'm in the right phase of my life or career. People still put me up against a corner. They're like, pick an age, pick a time. When's the right time? So we do know that as you look at all of the data, as you get older, your egg count goes down. And as you get older, your chance of problems go up. And something does cross around 35. With that said, if you look at the standard deviations and all the information that's out there, there's probably no difference between 32 and 37 and a half. So if you're within that messy middle group of 32 to 37 and a half, you shouldn't have any regrets that you didn't freeze your eggs earlier. Just go talk to someone about it if it's something you really want to do. And if you're below 32, you should just know that something happens statistically around 32. So try to freeze your eggs before you're 32. But neither you nor I have a time machine. So if you're outside of those windows, I can't make you go backwards. So just go see a fertility doctor and just go talk to someone about what you want to do and what your reproductive goals actually are.
Thank you. Well said again. All right. Some questions around the length of the IVF process. So if you could actually speak to the length of the process and what it entails for both egg freezing and IVF, that would be great.
Sure. So I would open this by saying that personally, I'm neither known as a very fast doctor, which means I don't rush people to treatment. And I'm not known as someone who's like jumping the gun, right? I like to figure out who the patient is and to figure out what treatment they require. So in my approach to IVF, it almost always requires a month of evaluation. That might be learning what you look like on day 2 or 3 of your natural cycle, and almost always preparing your body to go through a cycle of IVF or taking shots. That might be the estrogen patch or estrogen pills, or maybe it's doing Lupron before, or maybe it's actually giving you birth control pills. Many clinics don't view that first preparatory month as important, and they rush people right in, and they're just like, oh, nice to meet you. Want to take some shots? That's just not my approach. That's not the way I like to do it. With that said, almost all IVF protocols start with someone getting their period. So on day 2 or 3 of your cycle, whenever you're bleeding, you would come into the clinic, get blood work and ultrasound, and then you would self-administer injections for 10 to 12 days. The reason you need 10 to 12 days of shots is because it typically takes 10 to 12 days to make a mature egg, right? It takes typically 10 to 12 days for your cycle to make your egg. Then you ovulate. And then about, if you're trying to get pregnant on your own, 12 days later or 14 days later, depending when you did ovulate, would be when your period would be. And that would be an idealized 28-day cycle. So what we do with IVF is we try to just mimic Mother Nature. 10 to 12 days of shots. You take a trigger shot at the end of that, and then you have a surgical procedure to retrieve your eggs, typically 36 hours after the trigger shot is done. Egg freezing, IVF, no different, both the same length. The only difference is that if you're talking about doing an embryo transfer, in some clinics, they do a fresh embryo transfer, which means after you get the eggs retrieved, 3 to 5 days later, they may put back an embryo. Or if you're in our clinic, and typically with the patients that I tend to treat, you would actually make your embryos in the lab, let them grow for a full week. We let you get your period. And then the next month, we put back an embryo, a single embryo at the right time in your cycle when it's idealized.
Thank you again. All right, let's talk about supplements for a bit. Do you recommend taking supplements before egg freezing? That was a good one that came in.
Yes, yes, and yes.
Okay, and is there an optimal time of day to take supplements?
Amazing question. So whoever asked this one is my new favorite a panelist or a attendee, because this question is so important. Jenna, big thumbs up to you. And the reason this question is so important is that most people don't view supplements as a medication. And most people don't view supplements as something important. They're like, oh, by the way, just gonna take my vitamins. But if you, for example, have a thyroid condition, and hypothyroidism is the most common medical condition that a young reproductive age woman will have. And if you take Synthroid or synthetic thyroid hormone, which is the most common medication that reproductively aged women take, you should know that vitamins can mess with your thyroid hormone levels if you're taking synthetic thyroid hormones. So if you're not taking any medications, you should try to just take it at a time that you'll remember to do it. I take my vitamins in the morning because I leave it next to my toothbrush. And so I just remember to take it when I'm brushing my teeth. With that said, if you're someone who takes thyroid hormone, which has to be done on an empty stomach and then not eating for 1 hour later, what I'd say is leave your vitamins at your desk at work. Maybe you just want to leave it next to your phone or next to your computer or something like that. It doesn't really matter when you take it, but just be aware that vitamins can mess with your medicines.
Okay, thank you. And if you're trying to get pregnant, how many months in advance should you start to take vitamins?
So, it's such a hard question because whatever the answer is, someone's going to be like, gosh, darn it, I should have done that 1 month before that. But in reality, most people weren't planning to get pregnant when they did get pregnant, and most people wanted to get pregnant, after they did get pregnant or before they got pregnant. And so the answer is, look, whenever you're on your journey, start your vitamin supplementation. You can hold yourself responsible for a lot of things, but you can't hold yourself responsible for doing something that you didn't know to do. So today's your call to action, right? Like if you're not taking any supplements, then go sign up for Perelel, like go get your discount and go enjoy it. It's easy. If you are taking supplements, well, then mazel tov, like keep going. But I would just say like, do it when you can and try to remember it. And, even if you're months away or years away, they're most likely, you will benefit from just getting a better diet and getting better supplementation on board.
Thank you. I'm going to add a plug for also just finding out more about your fertility now.
Yeah.
Like there's never a better time than now to just learn more about where you stand, whether it's taking a test at home or going into your OBGYN or, fertility doctor and just getting an assessment. No time like now.
And I'll also just say, it's almost become normal for someone to talk about their egg freezing journey or the fertility journey at dinner, right? Like it almost feels like it's pretty normal to have these conversations. So bring it up with your friends, right? Like there's nothing like the support of your colleagues to know that you're not alone. And most likely you can actually help support each other and help each other from like going through the hurdles and the hiccups that you may have experienced by just pointing out some of the pain points that you had.
Yeah, absolutely. This is an interesting one. Is there a con for taking folic acid before you are pregnant or trying to get pregnant? Should you wait? Like if you're just going about your life, is there any reason you wouldn't want to take it?
So taking super therapeutic levels of folic acid, which means taking more levels than you could absorb, is never good. So don't go nuts. I would say like taking a normal level of folic acid, not going to have any harm. In the United States, we do fortify a lot of foods, right? Because the fortification that we do is adding folic acid or folate to certain foods so that we don't have all these neural tube defects, which is why you take folic acid, like all the great work from the March of Dimes. But in general, there's no harm to preparing your body, and actually getting into a routine for something that's going to be really important for when you are pregnant is a good thing.
Yeah. Yeah, makes sense. Okay, just a few more questions before we wrap up. A few more about IVF. Medications. Medications are very expensive. We have a question around whether it's okay to take the generic, slightly cheaper versions. Anything you can share generally about medications would be great.
I'd love to know where the generics are coming from, because there are no generics in this country. We have had such little innovation in the pharmacotherapies or the drugs that we use in IVF in the United States in the last 20 years. We pretty much used three main stimulants: Gonal-F, Follistim, and Menopur. Well, Gonal-F and Follistim are essentially the exact same drug, just made by two different manufacturers, and actually the same company as Merck, but one is Merck in the US versus Merck in Europe. And then there's Menopur, which is a Ferring Pharmaceuticals product. There's another drug that will be coming down the pike in probably the next 18 months, and that's super exciting. But in this country, we don't have generics. Now, if this person is saying, I can get generics because they know someone who knows someone, and they're getting them shipped in from Canada or Israel or India, I would just say, be aware that temperature regulation is very poor in general in the medications that people are getting from outside the country. When pharmacies are getting medications from other countries, they're sent in temperature controlled containers. When you're ordering something that's being delivered to you from Israel or Canada or India, or wherever else, there's a chance that there's been extreme temperature variation. And this might seem like a minor point. However, I have a patient I had to call this afternoon to say to her, hey, I know you told me you're taking drugs for the last 6 days, but there's no evidence of it in your blood. And most likely what happened was that either her medications froze and had a thaw and had a weird reaction, or they just sat out on a pallet in a hot sun and then got deactivated. So be careful. IVF is expensive. It's emotionally expensive. It's physically expensive, and it's financially expensive. And don't rush to find a cheaper option on the drugs by using an international opportunity, because it actually could be a way to sink your cycle.
Yeah. All right, just a couple more. And if there's something that hasn't been answered that you're dying to have answered, please reshare it. That would be great. Someone asked about the protocol that their doctor recommended for IVF, and they're struggling to understand if it's the right protocol. It's called the long protocol, and they're worried that that's going to take a long time and might be more expensive. What is your recommendation there?
So if the long protocol is what we call long luteal lupron, or LLL. That is one of the first protocols that was developed for ovarian stimulation in the mid 80s. And by the late 80s, we realized that patients were not so tolerant of going through what really became an 18-day experience of taking Lupron for all that time. With that said, long luteal Lupron protocols are good for a choice group of patients. Those who are either low responders, those who have egg quality problems, or those people where it's the right protocol. What I can say is that for me as a practitioner at CCRM, I'm indulged by having 11 different protocols that we can use. more than just the standard 4. So we have different cocktails, different approaches, and different ways we do it. And if you're having concerns or doubts, this means that you most likely also aren't partnered with your doctor the right way. And so your doctor owes you partnership, right? This is a journey. Your doctor's success is your success. And so what I'd say is, like, take this as maybe either a red flag that you need to go talk to your doctor, or take this as a red flag that maybe you're just not in a clinic or in a setting that's the right one for you. Because you never should be doing something blindly. And you should have the support that you need and deserve to get through what's a really challenging experience.
Thank you. Okay, we're just going to do, let's say, 2 more, and I'll reward the ones that reshared just now. What is the best way to tell if you might have endometriosis or
Amazing.
PCOS?
Not amazing. Okay, so to tell if you have endometriosis,
You're on mute now.
I'm on mute.
Yes.
I can hear you, Dr. Levine.
Oh, okay.
That was me. Keep going.
So the number one way to know that you have endometriosis is to have cyclical pelvic pain, pain with your period, pain in the day right before your period. Another way to know is that if you have pain with intercourse or chronic pelvic pain. But we are so bad at discussing pelvic pain in this country that we need to figure out a better way to do it. If you're missing work or missing school, or you're taking a handful of Advil, or you're finding that you need to have a really good heating pad at work and a really good heating pad at home, you need to talk to your doctor about endometriosis. It is a real condition. It is really out there. It's not in your head. If you're someone who's like, my stomach gets so upset every time I get my period, you actually might have endometriosis, where it's irritating your bowel and causing you to have irritation and have either like constipation or diarrhea or something like that. We need to discuss more often pain, when it happens, how it happens. So use your phone, right? Like, you have a calendar app, no matter what phone you have, and just write in there when you're having pain. You can even just call it, pain. And then you just search your calendar for pain, and all of a sudden you'll see all the days that it comes up. When it comes to PCOS, as I said before, there are 3 criteria that you need to be defined by it. Don't fear the diagnosis. In fact, you should feel rewarded if you get to have it, because then at least there's a simple plan, right? There's an evidence-based approach of how you approach a patient with PCOS, but it's irregular cycles, lots of follicles on ultrasound, and then evidence of hyperandrogenism, which is either having facial hair, which is hirsutism, or greasy skin, or pimples, or testosterone in your blood.
Thank you. And we actually do have a test. There's not one test for PCOS, but we do have a test that looks at a number of different hormones that maybe you can speak to, Ashley, at Let's Get Checked.
Yeah, so our PCOS test is not diagnostic. Like Dr. Levine said, there's the 3 criteria that doctors look at. It's really a clinical diagnosis in some cases, but we're looking at high testosterone levels with that. So to see if you have that hyperandrogenism in your blood, that elevated testosterone. So, and there's some other labs in there as well that can be associated for women who have PCOS. So sometimes you'll have differentiations of your LH levels. So it includes FSH, LH, and we do offer AMH testing as well. So sometimes women with PCOS will have an elevated AMH levels. So several different lab tests that can be looked at, but really the one that would be used for diagnosis is the testosterone level.
Great. We are at the hour that flew by, and there are so many questions, so we should do this again. But thank you for all the questions for the panelists. You've been amazing. I'd love to just see if you have any final thoughts to share with the group tonight.
So I'll just end by saying that it is National Infertility Awareness Week, but awareness shouldn't stop this week, right? Like, help support anyone that you know that might have trouble getting pregnant or staying pregnant, or maybe it's just pre-contemplative and just thinking about it, right? We need to start normalizing the dialogue. And so I hope with the other 51 weeks this year, there's going to be conversations that we all feel comfortable to have with each other, and we support each other. The other thing I'll just say as a quick plug, if you know anyone who has the devastating diagnosis of breast cancer, remind them that egg freezing is out there. It is still surprising and sad to hear that so many people have the diagnosis of breast cancer and don't know that egg freezing should be that next step to help protect and preserve the fertility. before going on an incredibly difficult challenge, which could be chemo or radiation or surgery or all of the above. So if there's anything you can do after this talk tonight to help others, is remind people that if you get the diagnosis of cancer, please go talk to a fertility specialist about freezing your eggs, and talk to your oncologist about this as well. So thank you for hosting tonight, and thank you to everyone for staying.
Thank you so much. It's been so wonderful to have you here with us to talk about this topic. And thank you all for joining. We'll be sending out an email with a link to the recording, as well as those discount codes for both Let's Get Checked and Perelel. So no better time than now to take action. And yeah, let's keep broadening the conversation and talking about this. Thank you so much.
Thanks, everyone.
Bye-bye.
Have a good night.